Hi, this is Brian Kim. I'm going to share with you this case of a patient with an intumescent white and dense cataract, and I'm going to be doing the double Rhexis technique to prevent the Argentinian flag sign. And so, when you have an intumescent lens, you have a lens that's very convex, and so as you're making the Rhexis, it tends to radialize, and so that's the classic Argentinian flag. And so this is a double Rhexis technique where you make a very small Rhexis, remove the cortical material, and then make your normal size Rhexis. As you can see here, this is a white but also brown intumescent lens. This is a pretty dense cataract. And you can see that the lens is bulging forward. You can see the appearance of the lens itself. It's got this very crystalline, sparkly looking appearance. I'm using a cotton tip to steady the eye. I'm using a corneal marker to help me center and size my Rhexis. You can see this patient is not really very cooperative. I'm having to hold the eye steady for this patient. Making my paracentesis incision on the right side and then the left side. This is a right eye. And I'm using the cotton tip to steady the eye. I'm making my incision flat to the iris plane so I have a nice corneal shelf, which will allow me to have a self-sealing incision. This is intracameral lidocaine and then some intracameral air. And then I'm going to put some trypan blue to paint the anterior capsule surface here. And again, I like to paint the surface of the eye almost like a paint roller and then drip it. I don't like to be too vigorous and risk getting some trypan into the posterior segment. I'm injecting some intracameral dispersive viscoelastic in such a way that it pushes out the bubble and the dye. And then this is a triplanar corneal incision. I'll make a vertical groove using the cannula to hold the eye steady in this patient who tends to move here. Turn the eye away from me, place the blade into the deep part of the groove, tunnel through the cornea, use a cannula to turn the eye towards me, and then I dive down. And that's the technique. So next is going to be the needle technique where I'm going to puncture the central anterior capsule and then aspirate very quickly to remove any of that lens material. You can see the lens material is liquidy, and I was able to remove some of that material pretty nicely there. Again, this liquid cortex is causing that bulging of the anterior capsule. And so I'm taking my time here, being very careful to make sure I get a small Rhexis, hoping that it won't radialize. And so I start the Rhexis here. And the idea being I'm going to make a small Rhexis because as long as I say fairly central, it should not radialize. It's only when I try to go out and make a larger size Rhexis where the Rhexis might want to run out peripherally. And so I'm making this small size Rhexis. You can see because of the forces, it's causing my flap to come to the wound. And so I'm having a little bit of trouble grabbing my flap, but I'm trying not to be nervous by that and not to do anything too aggressive. And I finally am able to finish the Rhexis. So I'm using my hydrodissection cannula to make sure it's free, but of course in an intumescent lens, it's already free. This is a mobile lens already with liquefied cortex. And so this is a key. Once you have that small size Rhexis, you place the INA handpiece within the hole there and remove that liquefied cortex. And so you have to go around circumferentially removing this liquid material. And so this requires me to rotate the lens as I aspirate that liquid cortical material. Now, the problem with removing all this liquid cortical material, the benefit is I'm able to minimize the chance of the Argentinian flag, which is really nice. The problem is by removing that cortical material, I'm in essence creating a Morgagnian cataract situation where I have a free-floating lens within a capsular bag without much cortical or epinuclear material that supports the lens itself. And so you're going to see that, and you're going to see when you do this maneuver, it does help with reducing the Argentinian flag sign. So it just makes it a little bit more difficult to disassemble the lens with traditional techniques. So surgeons who like to sculpt, I think, get a little bit more of a challenge in this situation. So once I'm done, I'm injecting more dispersive viscoelastic. I use my corneal marker, which will help me to center and size the Rhexis. And I did that again because it was a little bit difficult for me to assess the size of the Rhexis after all this manipulation. So I use a long Van Ness scissor to cut the Rhexis and to widen the Rhexis, which will allow me to create a little bit of a flap. And then I'm going to go around circumferentially, widening my Rhexis. Keeping in mind, I'm trying to make it fairly similarly sized to my corneal mark. But again, I'm being a little bit more conservative. I'm being a little bit smaller than my marks because, again, even though I did a good job removing that material, I don't want to risk getting that Argentine flag. So after successfully widening the Rhexis, I burped the viscoelastic. And again, I'm not hydrodissecting because I already made sure that the lens was free in the beginning. I'm going to place the chopper out to the equator underneath the Rhexis edge, turn the phaco tip vertically subincisionally, bringing both instruments together, crushing the lens and bisecting it completely in half. And by cracking and separating, I'm able to ensure both are free. I place the chopper around the contralateral lens, pulling it centrally and crushing the right heminucleus in half. I use a little bit of vacuum to pull that first quadrant up, and then I'm using mechanical fracturing forces to crush the lens pieces and emulsify the lens pieces. I use a chopper to get around that second quadrant. I'm pulling it centrally, crushing it against the phaco tip, and then I'm trying to, again, crush the lens between the chopper and the phaco tip, making sure I'm separating that second quadrant from the bulk of the rest of the lens. Use a little bit of vacuum to pull that second quadrant up, and then crushing it with mechanical fracturing forces and emulsifying that second quadrant. I'm turning that second heminucleus in front of me, place the chopper out to the equator, placing the phaco tip deep, crushing the lens completely in half, separating the lens pieces. I'm going after the third quadrant, placing the chopper out to the equator, placing the phaco tip deep in the bag, crushing and bisecting that third quadrant. I place the chopper around the lens piece again, sandwiching it between the chopper and the phaco tip, and then using high vacuum to pull that fragment up and emulsify the lens pieces. Getting around that third quadrant fragment up, crushing it against the phaco tip, further dividing the lens into smaller pieces, and then using ultrasonic energy and vacuum to remove the lens pieces. So this is a really dense nugget. You see I'm trying to crush it, and it's really, really dense. I can feel the density of that lens piece between the chopper and the phaco tip. And so that's why I like to use mechanical fracturing forces, because otherwise that'd be a lot of ultrasonic energy that I have to use, and again, potentially damaging the corneal endothelium. By crushing it, this really just bypasses that potentially harmful step of damaging the cornea. I place the chopper around that fourth quadrant, pulling it centrally towards the phaco tip, crushing that lens piece, placing the chopper around that fragment, pulling it towards the phaco tip, and then crushing the lens piece. You can see with these maneuvers, I'm not using much vacuum to crush the lens pieces. I'm just positioning the lens pieces mechanically and then crushing it between the chopper and phaco tip. And then when I'm ready to emulsify, I start to use high vacuum and ultrasonic energy. In cases when you're having difficulty positioning the lens piece, you can use a little bit of vacuum to help position you. So again, this is the last fragment. Again, I'm not using any ultrasonic energy or vacuum. I'm just manually positioning the lens between the chopper and the phaco tip, crushing the lens pieces, using a little bit of vacuum to ensure that I have it on the tip, and then crushing the lens piece. So again, I use the vacuum sparingly if I have to position the lens piece when I have to crush it with mechanical fracturing forces. And this is that final fragment. I positioned it against the tip with a little bit of vacuum, but then once I position it, I turn the vacuum off, crushing it with mechanical fracturing forces. And then when I'm ready to emulsify, I'm placing that chopper deep to protect the posterior capsule and emulsifying all the lens pieces. I take the chopper out, push BSS in, take the phaco tip out, and place the INA handpiece. And I'm going underneath the Rhexis edge for a cortical cleanup here. Again, it should be a pretty clean bag, but you never know. So I'm going around just making sure there's no cortex hidden. I do have some subincisionally here. I switch to the polish mode and I'm polishing under the Rhexis edge. And then I'm polishing the posterior capsule as well, removing any potential lens material here. And especially in this subincisional area, I thought I saw some remaining cortical material. I can be more confident, more aggressive by polishing in the subincisional area in the polish mode. Once I'm satisfied, I push BSS into the subincisional fornix to make sure there's no hidden lens material there. In this case, it's pretty clean. And then I'm injecting some cohesive viscoelastic to fill the bag. And then I use the sweep to polish underneath the Rhexis edge. First on the left side and then the right side. So again, with these dense lenses, I usually associate dense lenses with weak zonules, and so I tend to prefer a three-piece lens in this situation. So once I'm done polishing, I widen the incision with my diamond blade, and then I'm injecting the three-piece acrylic intraocular lens into the capsular bag. I point the bevel to the left, the leading haptic comes out planar, goes into the bag. I rotate my wrist, again to rotate, pronate 90 degrees counterclockwise so the optic comes out flat and the trailing haptic comes out flat pointing to the right side. I use a Maltzman to dial the trailing haptic into the bag. So it's back to IA. I like to go underneath the lens first, remove all the viscoelastic from within the bag. And then I switch to the visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you can see this is a perfectly centered and sized Rhexis here. Again, it's a little bit smaller than I usually do, but again, that's because I'm trying to minimize the risk for the Argentinian flag. You saw I did the double Rhexis technique, puncturing with a needle, aspirating liquid cortex, injecting some more dispersive viscoelastic to flatten out the anterior capsule, making a small size Rhexis, removing the cortical liquid material with the INA 360 degrees, and then injecting some more viscoelastic and widening my Rhexis to the normal size. And then again, you want to treat this type of lens like a Morgagnian cataract because it's still kind of mobile within the bag, and using mechanical fracturing forces, double chop, cross chop, I'm able to very carefully and systematically disassemble this lens. Again, because mechanical fracturing doesn't require vacuum, I'm able to very carefully and confidently disassemble the lens without fear of rupturing the posterior capsule. And also using mechanical fracturing forces helps reduce the use of ultrasonic energy, which will allow me to have clearer corneas postoperatively. So I hope this was helpful to you, and I thank you for your attention.